Today I'm going to start with the liver series, and in the liver series I would first like to start with the investigations of liver in a surgical point of view. In this module we'll also combine some amount of anatomy related to the liver. So the major function of the liver is the excretory or the detoxification function as well as the synthetic function. Here you can see the liver has lots of function. It helps in the production of cholesterol, it helps in detoxification, it helps in synthesis of proteins, the proteins such as globulins, which helps in the immune system, that is by forming the antibodies and immunoglobulins, and you have the albumin, which helps in maintaining the oncotic pressure and the fluid mechanism of our body. It also helps in storage of various micronutrients and production of bile. Okay, so in order to assess these functions, we have lots of laboratory investigation, and to know the anatomy or any other functional disorders, we have the imaging modalities. So it is through the ultrasound abdomen, the triple phase CT. It is a form of contrast CT. So CECT is a very important modality in the aspect of liver. And we also have fibroscan. Fibroscan is important aspect of medicine when compared to surgery. It helps to know how much cirrhosis has happened in the liver. So in the liver, how much cirrhosis or fibrosis has happened can be seen via the fibroscan. Okay, so now we are starting with the laboratory investigation. We have the very famous or very important thing called the LFT. So before any invasive or non-invasive procedure, we have to do this LFT, which is a functional blood investigation. Okay, so in order to remember what the LFT contains, what all it includes, there is a simple mnemonic, which is A, B, C. So A consists of four things: the serum albumin, ALT, AST, and ALP. So serum albumin, you can helps. We have seen that the serum albumin helps to maintain the oncotic pressure. The ALT and AST are indicators of any inflammatory activity that happens in the liver, and ALP is very important to know about any cholestatic activity happening in the liver. Okay, the second important thing is B. It gives the bilirubin. The serum bilirubin is assessed. So the bilirubin can be a direct bilirubin and an indirect bilirubin. Indirect bilirubin is also called as the unconjugated bilirubin. Okay, so bilirubin helps us to know what kind of jaundice is present, whether the jaundice is prehepatic, hepatic, or post-hepatic. Okay, so with C stands for the clotting. Okay, for clotting we have to identify the PT-INR, that is the prothrombin time, and INR, international normalized ratio. Why do we require all these laboratory investigation is a major question. So with these laboratory investigation, that is the LFT, we are going to assess the functionality of the liver as well as the prognosis of the individual, that is the mortality of the individual. So we are going to assess the liver function and predict the mortality. But how are we going to predict the mortality? We have certain scores. So what scores are these? First of all, we have something called the CTP score, that is the Child Turcotte Poo score, as you can see here. And the second score we have is called the MELD 3.0 score. Okay, so under CTP score, that is the Child Turcotte Poo score, we have these parameters. So to remember, we can remember it as A. A stands for albumin. One more A is also there, which stands for ascites. Okay, we have B. B stands for the bilirubin. Okay, anything related to liver should contain the albumin and bilirubin. E stands for encephalopathy. Okay, if there is ascites, there is high chance of development of encephalopathy. Okay, so we should remember encephalopathy. And I stands for nevertheless the PT-INR time. Okay, so this is the mnemonic that you can remember for the Child Turcotte Poo score, and these tell about the parameters. And why is this important is to assign it points. So when it is the point is for 5 to 6, we can group it under class A. When the point is 7 to 9, we can group it under class B. And when the point is 10 to 15, we can group it under class C. Okay, each tells about the mortality. So when there is in class A, there is around 10% mortality. In class B, there is 30% mortality, whereas in class C, there is a rate of 70% of mortality. Okay, So we should remember that each parameters contain 3 points, 1, 2 and 3, and these are the values. In hepatic encephalopathy, in point 1 there is no hepatic encephalopathy, in 2 there is minimum, that is grade 1 or 2 of hepatic encephalopathy, and in 3 it is advanced. So about hepatic encephalopathy will be explained in detail in another video. And in ascites, we can see that when there is moderate ascites, it is given 3 points. Okay, you should remember this. And as we already discussed, we need the CTP score to assess the liver function and predict the mortality. So when all we can apply this, we can apply it in the management of hepatocellular carcinoma and also for liver transplantation. Okay, and there are various other diseases in which we are also using the CTP score. So the second score that we are using is the MELD score. The MELD score is nothing but model for end-stage liver disease. There is a revised MELD score that has recently come up. So under this, the mnemonic to remember the parameters is F basic. F stands for female. B stands for bilirubin. So female sex is considered as a risk factor or a bad prognostic factor, and B stands for bilirubin. A stands for, as we have already seen, albumin. S stands for sodium. Yeah, this is a new thing to remember. S stands for sodium, remember it. I stands for the INR, and C stands for creatinine. Okay, these are the parameters that you should remember under the MELD scoring system. And what is the use of this scoring system? First of all, it helps in short-term prognosis in patients for TIPS procedure. As you know, in portal hypertension, we perform the TIPS procedure, and the MELD score helps to determine the prognosis. Secondly, liver transplantation. It helps to assess and prioritize the liver transplantation. And then we have the cirrhosis prognosis. To know the prognosis of cirrhosis, we use the MELD score. Whereas in pediatrics, we use something called PELD score. That is pediatric end-stage liver disease. Okay. Under this, we have the A, which stands for albumin, B, which stands for bilirubin, I, which stands for INR, and two important or new things that is seen in the pediatric group is age and growth failure as a parameter. We have to remember this. Okay, we have completed this course based on the liver function test. Now we are going to move further to the imaging modalities. So under imaging modalities, we are going to see the ultrasound abdomen. Okay, so this is the easiest, cheapest and fastest way to assess any anatomical abnormalities in the abdomen. What all you can see, you can find cyst, there can be solid mass, there can be congenital anomalies, and you can see the vascular arrangement also. The Mickey Mouse, the famous Mickey Mouse sign, which is seen in the ultrasound abdomen. It consists of, as you can see, the portal vein, the hepatic artery, and the common bile duct. Okay. The WHO has also used the ultrasound modality to classify the hydatid cyst. Okay, so it has classified, WHO has classified it as CE1, 2, 3, 4 and 5. So the CE3 is further grouped into CE3A and 3B. So we have 1, 2, 3, 4, 5 and the third is grouped as A as well as B. Okay, so as you can see, CE1 contains a unilocular anechoic lesion with double lines. So this is an anechoic lesion. The surrounding the anechoic lesion, you have double line sign. So this is the CE1. In CE2, you can see multiple rosette like honeycomb cyst. So you can see multiple rosette and it looks like a honeycomb cyst, right? The CE3 is further grouped into A and B. Remember, CE3A is what we call the water lily sign. It is a very important MCQ question. So in the water lily sign, you can see that the membranes are detached like this. So this is called the water lily sign. In C3b, you can see lots of daughter cysts in the solid matrix. So the matrix is solid and you can see some small daughter cyst. And in CE4, now we are progressing to CE4. CE4 is the dead stage, the inactive stage. You can't see any daughter cyst. Okay, so there is no daughter cyst and there is heterogeneous echogenicity. So heterogeneous echogenicity with hyperechoic or hypoechoic content can be seen. And as you can see, it is an inactive stage, so there is no daughter cyst. In CE5, it is a totally dead stage. It contains a solid pus and a calcified wall. The wall will be too much calcified. So in this transition, you can say that CE1 and 2 is an active stage. It consists of cyst and a multiloculated cyst, multiseptated cyst. So it is an active stage. In CE3 stage, it is a transitional stage, as there's a transition from active to inactive stage. The 4 and 5 is an inactive stage. Okay, we have to remember this hydatid cyst classification. It is very important. Moving on to CT or computed tomography. CT abdomen is a very important investigation involved in the liver. In this CT, you can see the coronal section, and this is the liver. The anterior part of the liver is seen, whereas the posterior part of liver is not seen. To understand the anatomy of liver, you can see this image. Let's say that you hold your right hand in the form of a fist as shown in this picture. The thumb finger, which has gone inside, indicates the first segment. Okay, so how are we dividing the segment? To see how we are dividing the segment, we have to know that the liver, as shown in this picture, is divided into left as well as the right lobe. Okay, the left lobe and right lobe is divided by the Cantley's line, which is the vertical passing from the IVC to the gallbladder. And under the left lobe, we have lots of segment. These segments are called the coinoid functional segment, which has individual artery, vein, as well as the bile duct. Okay, biliary branch. So in this segment, we have totally 8 segments. As you can see, the first segment is the posterior segment, which is located downward and behind. So this you can imagine by holding in the form of fist, with your thumb in. The thumb will be your first segment. The second and third segment is in your index finger. The upper part is the second segment. The lower part is the third segment. The fourth is the middle finger. So this is the fourth segment. This can be divided into 4A and 4B. The upper one being 4A, the lower one being 4B. And the other segment, that is 5, 6, 7, 8, will be in a clockwise fashion. Okay, so this is, as you can see, the 5, 6, 7, 8 is seen here. The 6th and 7th segment is a posterior segment. So when you see a coronal section of the liver, you can't appreciate the 7th and the 6th segment, which is situated posteriorly. So in this section, you can see the second segment, the third, the fourth, the fifth, as well as the 8th segment. Okay. So we have seen some amount of anatomy here. Now we are going to discuss about the liver abscess. We usually order a CECT, that is contrast enhanced CT, and in the liver abscess, as you can see a central hypoechoic pus. Pus is a fluid filled structure, so it appears hypoechoic. And via CECT, you can determine the size, location, and there can also be therapeutic advantages, as you can aspirate via CT guided aspiration. We also have one more called the triple phase CT. So this is also a contrast enhanced CT, in which you are infusing the contrast, and then you are passing through X-ray beams and seeing the various phases of the contrast. So there are 3 phases: the non-contrast phase, the hepatic arterial phase, and the portal venous phase. This portal venous phase is actually a washout phase. Some resources also say that there is a 4th phase called the delayed phase. Okay. So the non-contrast phase is usually a hypodense type of lesion. These are used in various diseases such as the hepatocellular carcinoma, FNH, hemangioma, and adenoma, focal nodular hyperplasia. Okay. So why do we use triple phase CT in these cases? First of all, this helps to characterize the vascularity of the vascular tumor. Okay, so what is the vascular origin of the tumor can be seen. We can differentiate hemangioma, hepatocellular carcinoma, and metastasis through this triple phase CT. So how are we going to do this? So in order to do this, we are going to see, first of all, in the first phase, second phase, as well as the third phase. The first phase, as we discussed over here, it is a non-contrast phase. The second phase is a hepatic arterial phase. The third phase is a portal venous phase. In the first phase of hemangioma, you will see a hypodense structure. Okay, so as you can see, a hypodense structure is seen in hemangioma. In the second phase, that is the hepatic arterial phase, there will be a peripheral nodular enhancement. Okay, so you can see there can be a peripheral nodular enhancement, and in the portal venous phase, there will be a homogeneous enhancement. Similarly, in hepatocellular carcinoma, you can see there is a hypodense lesion over here in the first phase, that is the non-contrast phase, whereas a hyperdense lesion can be seen in the hepatic arterial phase, and there will be a total washout. That is, you won't be seeing anything and no contrast will be seen. So there will be an early washout in the portal venous phase. Whereas in MELDs, it's very easy to remember. You are going to have hypodense phase in all three stages. Okay. So this is one thing must that you should remember. And lastly, we are going to see, on the basis of this triple phase CT, we are going to have this LIRADS staging, which is liver imaging, reporting and data system. So this is similar to the TIRADS and BIRADS we have come across. So under LIRADS, we are going to classify the liver tumor as it is benign, or it can lead to, or it is a hepatocellular carcinoma. Okay. So in LR1, we can say that it is definitely benign with 100% certainty. LR2 means it's likely benign. LR3 means there is an intermediate likelihood of hepatocellular carcinoma. LR4 has a strong indicative, that is, it is likely hepatocellular carcinoma, and with LR5 we can say it is definitely hepatocellular carcinoma. So hepatocellular carcinoma is LR5, benign is LR4, and the LR2, 3, 4 range in between them, 2, 3, 4. Okay, so you can 3 is intermediate, 4 is likely. So that's it for today. We're going to see a quick revision of what we have learned so far. So we are going to we saw about the investigation, the functions. So under investigation, we saw about the liver function test. It consists of ABC, albumin, ALT, AST, ALP, B for bilirubin, C for clotting. Okay, and with this liver function test, we used it for CTP score, which is a prognostic index which predicts the mortality, and these are its parameters. And it has 3 classes, A, B, C, each having different points and indicating different mortality probabilities. And it is useful for liver transplantation and management of hepatocellular carcinoma. We also have the MELD scoring system. The F basic is its mnemonic, and it helps in determining the prognosis of cirrhosis. For pediatrics, we have the PELD scoring system. We should remember this. And for ultrasound abdomen, we saw the classification of the hydatid cyst into CE1, 2, 3, 4, 5, 1 and 2 being active, 4 and 5 being inactive, and 3 being the transitional. 3 is further divided into A and B. Okay. And under CT, we saw the anatomy of the 8 segments, how you can form a fist, and you can identify the segments, localize the segment, 6 and 7 being the posterior segment. The liver abscess, we saw triple phase CT. So under triple phase, the phases of contrast is being, the 3 phases of contrast is being seen via a series of X-ray beam, and it is the phases being non-contrast, hepatic arterial and portal venous phase, and these are the differentiating factors between hemangioma, hepatocellular carcinoma, and metastasis. And in the non-contrast phase, all 3 are hypodense, as you can see here. In the hepatic arterial phase, the HCC is hyperdense and metastasis is hypodense, whereas in the homogeneous enhancement phase, as you can see, is present in hemangioma in the portal venous phase. Okay, and then we saw the LIRADS staging. The LIRADS staging helps to predict or determine if the tumor is benign or it is a hepatocellular carcinoma. Thank you.